I'm Cindy McGrath, Communications Director at the GIC. Paul Murphy is our Director of Operation, and Donna Wortman is our Assistant Director of Operation, and Judy Satana is our Public Information Supervisor, and I'm sure you all know them. I think most of you know what's going on with the state's budget. We've got a huge deficit right now, and unfortunately the GIC is part of that deficit. We went into this fiscal year knowing we had a $125 million shortfall. Most of that is structural in that our base was never increased to cover all of the additional members we've added over the last few years. So you can see that in 4 years, our enrollment increased 25%, but our budget base did not increase in a corresponding manner. We've been able to patch it through for the last few years with supplemental budgets, but at our $125 million, that's not something you can easily patch together. So the other issue is that two of our larger health plans have been spending more than was projected, and I will speak a little bit about some of the reasons that our healthcare costs are going up so much. So this year, this slide you've seen before in different iterations, but this shows the state's budget as a whole and what's happened over the last few fiscal years with how healthcare is crowding out other expenditures. So as more of state funding is going to healthcare, other important items, including local aid, have decreased over that time period. This is a big factor in our costs. This is showing where Massachusetts patients are spending their healthcare doctors as far as hospitals. And too many of us are using the expensive academic teaching hospitals for routine care. These teaching hospitals do amazing things, certainly complex conditions. It's important to get the best care you can. But if you have something simple like a broken arm, you don't necessarily need to go to Massachusetts General Hospital, which, as you can see, blows away everybody as far as costs. Some of the other most expensive hospitals, Brigham and Women, UMass Memorial Center, and you may be aware that Unicare right now is in negotiations with UMass Memorial as far as the costs that they're demanding. They're demanding increased prices. We had a similar issue with a short while ago. Tufts was negotiating with them. Again, they're commanding very high dollars, and a lot of the doctors and hospitals, they think they are immune to taking any kind of being part of the solution to rising healthcare costs, and we can't just keep writing blank checks to these providers. So this shows, these are results from CHIA, and they did this analysis showing where the healthcare dollars are being spent. So the premium increase requests that we received from the plans averaged 9.5%. The administration has committed to bringing our base up to where it should be to cover the amount of enrollees that we cover, but they were not, there's not the money to have these kinds of increases. So as a result, some major benefit changes are happening for July 1st. I sent you out a recap of those after our February commission meeting. But because of those benefit changes, the average weighted premium increase is 5.7%. So centered care is the initiative the GIC embarked upon when we went out to bid for all of our health plans, where we're trying to change the way health care is paid for. Right now, the way it's paid for is per procedure, per test, per visit, and in and of itself, that's a very inflationary way to pay for care. What we're trying to do is move towards global payments or ACOs, where a group of providers are paid to take care of the individual. We call that the Centered Care Initiative. The idea is that the PCP coordinates the care and helps manage the patient's care, makes sure the patient knows what the patient's taking for medications, knows what tests and procedures have already been performed, and helps to coordinate the care from a quality and cost standpoint. So in keeping with this, we are changing the Harvard Independence Plan and the Tufts Navigator Plan from PPOs, which is a preferred provider organization, to a point of service plan. So what this means is there is the same wide network of providers. What's changing is that the plan now needs to know who the PCP is. So members are going to need to contact the plan either on the web or by phone or at our fairs to designate their PCP, their own, as well as their spouses, their covered children. And if they need to get referrals to specialists for the highest quality, highest benefit level, the lowest out-of-pocket costs. If a member does not switch plans during annual enrollment, they will stay in the plan. It's just that the plan becomes a POS plan. So those are the key points on this change, and I'm going to have Harvard and Tufts talk a little bit about what members will be seeing as far as communication to members and how it works if a member goes to a specialist without a referral. Elaine and Jennifer? All right, Jennifer Curcio from Tufts Health Plan.
Thank you. Good morning, everybody. As Cindy mentioned, I thought I was a teacher. Good morning, boys and girls. So Tufts Health Plan Navigator is moving from a PPO plan to a point of service plan. As Cindy mentioned, that does mean a primary care physician is required in order to have the lowest out-of-pocket costs. So what we're doing to assist members is we are doing a pretty extensive communication plan. It's beginning with a postcard that's going to be sent out to all members, letting them know that they do need to choose a primary care physician and they do need referrals for most of their specialist visits. The postcards are going to be two different versions. We currently have about 18,000 people that have a primary care physician already designated with us. So we're going to hold that information and just carry it on over. So those folks are getting a postcard letting them know, thank you for telling us who their PCP is. If you want to remain with that doctor, you don't need to do anything. And then it's going to tell them a little bit about referrals. And then the other mailing with the postcard is for everyone who does not have a primary care physician designated with us, to let them know that they do need to choose one. We are going to be attributing or assigning a primary care physician to all of the members just to be sure that they have somebody on file for July 1st. The way we're doing this is about 80% of those members that are left can be attributed to a primary care physician based upon their claims experience. So they've seen a doctor regularly, we have that record, and then we're going to be sending them a letter with that doctor's name saying, you know, our records show that Dr. Smith has been treating you as a primary care physician. We're going to go ahead and put Dr. Smith on file for you so you'll have a primary care physician effective July 1st. If this is correct, great, you don't need to do anything. If you want somebody else, you need to let us know. And then the remaining folks that we don't have any claims experience for, we are going to attribute a primary care physician to them based upon geography. So we're reaching out to providers in the area, making sure that they have room on their panels. So, you know, we're not assigning somebody that already can't take any new patients. And we're going to assign them based upon where they live. Again, it's easily changed. They can call in, they can, well, I'll get into that in a second, but they can change it if they don't want it. But it is very, very important that they at least have somebody on file effective July 1st. So those folks will be getting a separate letter saying, you know, we don't see any records of any doctor visits with you, so we're going to go ahead and give you Dr. Jones. And if this is not who you would like, you can just let us know. Otherwise, you don't need to do anything. And again, all of these mailings and all of the messages are going to be consistent, explaining the referral process as well, because that's a new thing that Navigator members are going to need to remember starting July 1st. In terms of how they can tell us who their primary care physician is, at health fairs, we're going to have what we call PCP advocates. We're going to have 3 folks from our member services area, and we're going to have laptops with us. So if they wanted to come and tell us who their doctor was there, we would be able to take in that information. The mailings that we're doing do let them know that this option is available. They can also do it online. They do need to be a registered member on Tufts Health Plan because it is via the secure portal, because it's considered PHI, so it has to be done on the secure website. But I really encourage folks to go ahead and register because you can access a lot of information. If you're a registered member, you can follow your claims, see if when they paid, track deductible, etc. But you can also pick your primary care physician. And of course, they can always call into member services to give us the information. We are going to have an option so they don't have to wait, in queue with all of the other GIC members that are calling with benefits questions, etc. We're going to have an option like press 1 if you're calling about your primary care physician. So we're hoping to keep the calls with a very low average speed of answer. It's a lot of changes for members this year. We totally recognize that. So we're trying to make it as least disruptive as possible. Again, if they do not use their PCP with referrals, they will be subject to the higher out-of-pocket costs. They would be covered on the unauthorized level of benefit. So we just definitely want to make sure that they have a primary care physician and that they're able to get referrals for any services that are to specialists.
And Elaine Wilson from Harvard.
As you've heard, Harvard Pilgrim is moving from a PPO, the Independence Plan PPO, to the Independence Plan POS. We're very excited about that as well because we're as engaged as all of the membership and everybody in the Centered Care Initiative, and moving over to a POS gives the member the primary care physician who will help them manage their care. The way that we will collect primary care physician information is various, so I will tell you all about that. We've looked over all of the PPO claims within the 70-some-odd thousand folks who have Harvard Pilgrim Independence Plan, and most of them do have a primary care physician, and most of them do have a doctor on file with us, so that's good news. About 90% of the PPO members do have a primary care physician on file. However, they haven't needed to have a primary care physician, so the message to your members is, if we've got a doctor on file and the member would like to change it, they may change it at any point. They just need to call or go online and change it through their Connect account. We will be reaching out to all of these members first at the beginning of annual enrollment with a letter to the subscriber saying, hello Elaine Wilson, we know you're on the PPO and we believe this is your doctor. We believe these are the doctors for your dependents. If that's correct, you need to do nothing. Then we let them know about the differences between the PPO and the POS. If they would like to change that, we give them directions how to, either through Harvard Pilgrim Connect or by calling our 800 number. It's easy, the member may do it at any time. We will reach out to all of them again during annual enrollment with a phone call to remind folks to pay close attention to who we have listed who that is their doctor and how to change it if they would like. And then after annual enrollment, after you've sent the GIC all forms for everybody and we receive the files, we'll then know who truly is a member of the new POS in the month of June, and we will send them another letter confirming their doctor. There's a segment of folks who do not have a doctor on file with us. That's about 10% of the membership. All of them will also be getting a letter. Their provider will say unknown. And if the provider is unknown, that's a real signal to the person, gee, I need to pick a doctor. But if somebody gets to the month of June without putting a doctor on file with us, or if they're brand new to the plan, maybe they've just joined for July 1st, at that point we will assign a doctor to them. That will be based on the fact that the doctor's panel is open and that the doctor's close to the member, so that on July 1, every person has a primary care doctor. And if they wish to change it, again, it's very easy. They simply need to call or go to the Harvard Pilgrim Connect site and change over who their doctor is, and we'll give everybody directions for that. So those are the ways we'll be gathering PCP data. And I think you know members will need a PCP and they'll need to have referrals. If the member chooses to use the network without a referral, they may do so. We encourage folks not to do that, though, because their coverage will not be as generous. If a member goes ahead within the network, as they could stay on the PPO and sees a specialist without a referral, they have coverage, but they're covered as if they were out of network with deductible and co-insurance. So it's good to be aware of that, because folks will still have coverage. It's not as rich, and really the whole idea is to engage with your primary care physician and coordinate your care. That's truly the best way to get your care. It's part of the Central Care Initiative, so that is the focus for folks, and they will get the more generous level of coverage with that. And we'll be here afterwards to answer questions for you, so thanks.
Does anybody have major questions about this change? Yes.
I just wanted to confirm, when you talk about referrals, even routine things like the every 2-year eye exam, annual mammograms, all those things are going to need referrals?
The question is about annual eye exams and mammograms, if you need referrals for that.
Hi, so there are services that do not require a referral. Routine eye exams do not require a referral. Any OB/GYN services do not require a referral, whether it be routine or non-routine. Mammograms do not require a referral, and chiropractic care does not require a referral. So these are going to be listed out for the members on their materials as well to make them aware, but you're absolutely right, not every service requires a referral.
And the same is true for Harvard Pilgrim as well, and folks will see that in all their printed materials.
Yeah, Linda?
Can we get copies of what's sent, not for everybody, but just one set of copies? Because they're going, my people are spoiled, I guess. They call me for everything.
I'm going to show where the contact information, but if you need something sent to you, you can always go through the website. We've got a lot of materials this year, so just be aware of costs that are involved. Yes?
What about Spirit?
There's no change with Spirit.
Oh, it's still, you don't need referrals.
You don't need a referral. It's a smaller network, but you don't need referrals. Yes.
Can you tell us the difference between if you didn't get a referral but we wanted to go see a specialist within the plan, what that difference is?
Yeah, so the difference is if you are going out of network. So if you don't get a referral and you go to see a specialist, it's like getting care out of network, higher out-of-pocket costs.
Is that listed somewhere?
That's everywhere in the guide. It's everywhere on our website. Yes.
What if you got a referral, like the doctor that they wanted to go to? You know what I mean? They refer you to this one, but you'd rather go to somebody else.
So the point is to develop a relationship with your primary care physician, and in such, I mean, personalities sometimes clash. They could give you a referral to another specialist in that field. So yeah, that's absolutely. If you went to your dermatologist and hated her, you could go to your primary care physician and be like, this really just isn't working out. And again, the whole point is to develop a relationship with that primary care physician so they can
Let it know if you have to go to the one that they wanted you to go to, even if you didn't.
No, I mean, I have found, no, I totally hear you. I have found oftentimes they give you a choice. You know, when you know, someone in my family needed to go see a specialist, they were like, well, here are a couple of options, and you know, do you have a preference, male, female, etc. So if it doesn't work out, you can get another referral. And if your primary care won't do that, you can change your primary care physician as well.
Yes.
You go to one referral and they tell you whatever, you go to another one and you want
Second opinions, yes. All right, I am going to move off this. If you have other questions, we just have so much that we've got to get in today. So prescription drugs, this is the next biggest juggernaut that's killing our costs. Specialty drugs in particular, they are projected to account for 9% of total medical spending. They are miracle drugs. People that are suffering from multiple sclerosis and very complex conditions need these specialty drugs, but their costs are going through the roof. In addition, brand name drug costs and generic drug costs are rising rapidly as pharma is consolidating and trying to hold on to patents longer and trying to milk any of their cash cows. And you can see what's happened to a couple of these drug prices over the last few years. So all of our prescription drug copays, except for the Tier 1 retail copay is going up for July 1st. These are the copay tiers and the corresponding increase. And then CVS Caremark was selected to continue as the pharmacy benefit manager for Unicare members. Prior authorization will be required for more drugs. I'm going to show you that in a minute. And after the first fill of certain specialty drugs, members must get their refills through CVS Caremark Specialty Pharmacy. So what happens oftentimes with specialty drugs is that the doctor needs to try a few different drugs to see if they work, and because these drugs can cost, you know, $3,000 or whatever, the idea is to try a drug for 14 days at the prorated copay, see if it works, and then they'd go through the specialty pharmacy. So these are the top 10 drugs that are going to be impacted by the prior authorization, just so you see. And basically what anybody that's taking any of the drugs that are affected, and there's a list of 25, but I couldn't fit 25 on the screen, would go to their doctor and say, you know, I have asthma, and the doctor's prescribing Symbicort. Could I take Advair or Dulera instead? What we are asking all of our health plans to do is have on their website an abbreviated formulary so that members can bring the formulary with them to their doctor visit and talk to their doctor about what drug makes the most sense for them. And you've probably heard about this. I did include it in the newsletter in January. There will be a lot of communications on this, but the OME plan for Medicare retirees is going to, the drug part of that plan will be switching to an EGWP plan on January 1st. We're going to automatically move everybody into the EGWP plan. This has a lot of features to it, the biggest one being that it saves money for both the Commonwealth and for the member. So low-income retirees may be eligible for subsidies and reduced co-payments. The benefits will match or be better than the Unicare non-Medicare drug program. More retail pharmacy options for filling a 90-day maintenance medication. So as you know, if you go to a CVS retail pharmacy, you can get your maintenance medications. You get a break on your copay when you do that. You won't get that break when you go to Rite Aid or Walgreens, but you can get your maintenance medications filled at those pharmacies. Similar to Part B, if you are deemed high income by Social Security, you'd pay a income-related monthly adjustment amount for Part D. Members should not enroll in an individual Medicare Part D plan. I've got that plastered everywhere. There's lots of communications to retirees and survivors to come. The vendor is SilverScript, which is affiliated with CVS Caremark. So if you see SilverScript or people ask about SilverScript, it's the Part D program for the EGWP program. So I'm going to have all of our plans come up and talk to you a little bit about prescription drugs. And as I mentioned, we're encouraging members to bring their formulary with them when they go to their doctor's visit. And all of the plans will talk about any management programs that they offer. You're talking about members who live out of state?
Correct.
Okay, so we have plans. Some of our plans are available in other New England states, and that's in the guide. There's the picture of the map that shows you what plans are available. Unicare Basic is the only plan that's available nationwide. That applies to everybody in the family needs to be in that plan. So if you have a divorced spouse, the divorced spouse lives in Atlanta, Georgia, and you want to cover that divorced spouse, the entire family needs to be in Unicare Basic if they're non-Medicare. That hasn't changed, right? None of our plans do. No. So unless you're living in one of the contiguous states that have coverage. So for example, Unicare Plus and Tufts Navigator and Harvard Independence. Are you in Rhode Island too? Yeah. Okay. So there are a few options in Rhode Island, for example. But if you live in Florida, the only option is Unicare Basic. Okay. No change in that. No change in that.
Good morning, everybody. My name is Joanna Penta. I'm here representing CVS Caremark. The CVS Caremark plan that I'll be discussing only applies to the Unicare state indemnity plans, so I just want to make sure that that's clear. I'm going to focus on pretty much 4 key areas of discussion. Number 1, I'm just going to touch on the copay changes and how your members are going to be notified of those changes. Number 2, I'm going to spend some time on the drug formulary. It's important that you understand that the drug list is changing, and I want to make sure that that's clear. Number 3, I'll just touch on specialty. As Cindy mentioned, it only impacts a very, very small percentage of your population, less than 2%, but it accounts for 25% of the total costs. So it's a huge driver of costs. And number 4, I'll touch on the EGWIP, Employer Group Waiver Plan. Number 1 on the copays, Tier 1, Tier 2, and Tier 3 copay changes. I just want to let everybody here know that we will be notifying every single impacted member that's impacted by a drug tier change or a person that's impacted by needing to get a medical necessity prior authorization for about 200 drugs that will require your physician to provide documentation that you've tried and failed several alternatives before you can take those particular drugs. We'll also be doing a special mailing to diabetes patients. Diabetes, insulin, there are drugs that are interchangeable. We are moving to preferred vendors, so there'll be a separate special letter going out to diabetes members because those folks really need to be assured and need the special attention. And number 4, we'll also be sending out letters to your specialty members, notifying them of some of the changes on the specialty drugs, as well as notifying their physicians. We are mailing letters on April 10th. This will give people plenty of time to make educated decisions on the various different options because there are changes that are impacting the Unicare state indemnity drug plans. Number 2, let's talk a little bit about the drug formulary. As I mentioned, there's about 200 drugs that will require medical necessity prior authorization. For those of you that don't understand what that means, a physician would have to provide us with medical necessity criteria as to why you need to be on what we refer to as non-preferred drugs. Again, the letters will be going to members, the letters will be going to physicians. We provide a list of targeted alternatives as well. There's also some changes to specialty drugs. Not only will there be some specialty drugs that will require prior authorization, as Cindy mentioned, you'll need to go through specialty mail pharmacy after the first fill. Currently, right now, if you get 2 fills at retail, any retail provider before you need to go to specialty, that's changing to 1. There's also certain drug classes that will be added to the specialty drug list. So if you have an HIV patient or a Hep B patient, a transplant patient, an infertility patient, those folks need to go through specialty pharmacy after the first fill. All right, the last thing I want to just touch on is EGWIP, Employer Group Waiver Plan. First thing I want to mention about EGWIP is, first and foremost, this is not to be confused with the individual Med D plans that are out there in the marketplace. You'll see SilverScript is a company that offers individual plans. SilverScript will be providing the group plan through the GIC. Basically, think of EGWIP as a big circle. There's a big portion of that are covered by the Med D plan, and then a small portion will be covered by the GIC. It wraps around. So really, in all honesty, your folks, other than getting inundated with information from CMS that are required mailings, there should be no real change to what a person sees. They're going to show their card, they're going to pay the same co-pays. It's just the Med D plan pays a portion and the WRAP pays the other portion. Lastly, I just want to touch on the website, as Cindy mentioned. We have a website available to members and to all of you that's very, very easy to use. It's www.caremark.com/GIC. You do not need a member user ID or a password, and there's a ton of invaluable information that will be posted on this website by April 10th. So if you go on today, you're going to see your existing benefits, but as of April 10th, you're going to be able to locate a pharmacy. You're going to be able to print the drug list. You're going to be able to go in and check drug cost. You'll be able to put in Viagra, which is now a drug that requires medical necessity, and it's going to show you what the alternatives are, and it's going to show you what the co-pays are. Oh yeah, April 8th. We were using April 10th, but we'll make sure it's April 8th. Thank you.
Hi again. For Harvard Pilgrim, the prescription drug plan itself is not changing other than the copayment amount. So anybody's prescription that is a tier 1 copayment today will still be tier 1. The formulary or the listing of medications and how they are covered is not changing. It's strictly the dollar amount associated with each tier for that change. And that's for the new Independence POS as well as the HMO and the Medicare Enhanced Plan for anyone with retirees who are covered. So just the copayment change.
Good morning, everyone. I'm Glenda DeBarge from Health New England. The egg book does not affect Health New England members. Members can go on our formulary on hne.com and print a PDF copy of the formulary. It's not all-inclusive, but it's not the condensed version, but Health New England is working on a more condensed version so members can bring it to their physicians. Again, that's on hne.com, formulary lookup. The copay changes are also affecting Health New England members. The formulary has not changed. However, there are programs in place, prior authorization and step therapy. With step therapy, you do have to try a medication first before getting the medication covered. For example, if you have drug A and drug B that treat your medical condition, you might have to try drug A first to have drug B covered. And if that doesn't work, then we will cover drug B for you. Prior authorization usually is with the tier 3 medications that have generic equivalents available. So for those brand medications, tier 3, you will have to have prior authorization. And then our specialty drug vendor is through Briova. Our Catamaran is our primary, PBM is our pharmacy benefits manager, but Briova is for our specialty medication vendor.
Good morning, my name is Julia LeBrun. I'm with Fallon Health, and pretty much with the other carriers. Fallon's formulary is not changing this year. Again, the only change is within the co-payment structure of the plan. Our entire formulary is available out on the website, fallonhealth.org/GIC. There's a nice link there on the first page for a member to access. They get the entire formulary. It's alphabetized. They can look up a drug and find out exactly what tier that drug falls into. We are working on obtaining that condensed list for a member to be able to print down the most common drugs. So we are working towards that. As Glenda had stated, our drugs too have always required, certain drugs have required a prior authorization or step therapy. Again, working through the member's provider to get that authorization for any drug that is necessary. And then again, with the step therapy, there are requirements for certain drugs where a member needs to try certain drugs first prior to being authorized to go on the end drug. We do have specialty pharmacy that is really through mail order, so a member is able to go to the pharmacy, retail pharmacy, pick up the first month's supply, but then when it is determined that it is a specialty drug, we want them to be utilizing the mail order drug program. So we will be contacting that member out. If they are new to filling that prescription, we will make contact with that member to let them know what form they need to fill out and where they should be obtaining that through the mail order. Just one other note is that Fallon does have a preferred generic program in place so that if a member is taking a brand name drug where the generic is available, not only do they pay the co-payment, but they pay the co-payment plus the difference between the cost of the brand name drug and the generic. That is nothing new. That has been in place for several years now, so there's no change there, but just wanted to make you aware of that.
Hi again. Again, I'm from Tufts Health Plan. The copay changes are also in effect for both the Tufts Health Plan Navigator and Spirit plans. Our drug formulary is staying the same. However, we do have the programs that my colleagues have listed out, the step therapy programs, the prior authorization programs, the quantity limit programs, and the generic preferred, where if there's an exact match for a brand name drug to a generic and you choose to take the brand name drug, there is an added cost to that in addition to the copayment. Those are not new. They're currently in effect on the plans and will be remaining in effect on the plans. One thing I want to note with the change on Navigator from the PPO to the POS, any member that has a prior authorization on file or has already gone through step therapy, all of that information is going to automatically carry over, so they're not going to need to like reauthorize their prescriptions. Member IDs are staying the same, and that's how we track that, so it's just going to automatically carry over. We have the maintenance medication mail order policy where you can get it through the mail, and you can also pick it up at a CVS pharmacy. That is going to remain in effect. And we have the condensed, show and tell, the condensed prescription drug, the most commonly prescribed drugs and where they fall is available on our microsite, tuftshealthplan.com/GIC. It's going to be included in the open enrollment materials as well. The full formulary, this is the most common prescriptions. There is the ability for a member to type in their drug. If they're taking something that's kind of uncommon, they can type it in and find out what tier it's on as well. But this is pretty good for the majority of the membership.
You can go to a regular CVS.
Yes.
Yes, you can go to a regular CVS for either a 30 or a 90-day supply.
Oh, you can do the 90-day for spirit too?
Yes, you can. Yes.
All set. Hi, good morning. I'm Eric Jakes. I'm with Neighborhood Health Plan. The programs that we have at Neighborhood Health Plan very much mirror what the other carriers mirror. If there's a generic version of a prescription available, it's certainly going to be that a member is going to be able to have. Keeps the cost lower. However, we all know that there are some medical conditions that require either a preferred brand or a non-preferred brand, and those can certainly be authorized if the doctor can provide plenty of information requiring that the medication be covered. We have a prior authorization program, a STEP program as well, if anybody does need to go on to one of those brand name prescriptions. We also have a couple of things that are a little bit different. Like the other plans, we do a 90-day supply for, let's say for example, simvastatin for high cholesterol. You can mail out for that, or you can actually pick it up at a CVS as well, 90-day supply, which is terrific. The cost is for a 2-month supply when you pick up a 90-day supply, so it saves folks money when they know that they're going to be on this prescription for the foreseeable future. We also have an over-the-counter drug benefit that, let's say for example, you bring your son or daughter in, they got a bad cough, Robitussin is recommended by the doctor. If they write a prescription, it's very likely you can bring it in and either have zero cost or the tier 1 cost, so you can save a few dollars on those. And that's always been available to our members. Another thing that I noticed is that Cindy mentioned diabetic supplies. If you're picking up test strips, for example, with Neighborhood Health Plan, those go under the prescription benefit, but all of the diabetic test supplies go into DME, and they have zero cost sharing for diabetic test supplies. So this is to encourage people to constantly get those diabetic test supplies resupplied, so they always have them to be able to check their blood levels and such. So that's something else that we offer to members so that they can stay on track and not have to end up in an emergency room with an issue because of their diabetes. So that's about it for me.
Any questions on drugs? Yes.
If I've been approved, say under neighborhood health plans and I move to community choice, am I going to have to get a pre-authorization again?
So the question is, if I switch carriers, am I going to need a pre-authorization?
The answer is yes, under CVS Caremark.
Yes, absolutely for Harvard Pilgrim. If you're new to the plan, you do need to go through that process.
And step therapy also?
The same for Health New England.
Yes, again, across the board, because you are switching carriers, those prior authorizations, those step therapies, all of those notes that the current carrier has, those are not carried forward. So when you are switching from one carrier to another, you will need all those processes redone.
And you meant to say when you're moving from community choice to NHB, right?
Yes, I did mean to say that.
Any other drug questions? Yes. No, the question is, do all of the plans use CVS Caremark? No. Unicare and Tufts use CVS Caremark. Each of the plans can say who else they use.
Our pharmacy, with Harvard Pilgrim, and our pharmacy benefit manager is MedImpact, and it does include the CVS pharmacies, but it also includes other pharmacies like Rite Aid, Stop and Shop, Walgreens. Think of a pharmacy, it's probably on the list, and local smaller pharmacies as well.
Retail mail order for Health New England is Catamaran, and for the specialty vendor, it's Briova. Fallon does use CVS Caremark as its PBM. Tufts Health Plan does use CVS Caremark as its pharmacy benefit, but you can fill non-maintenance drugs at other pharmacies. You don't have to go to CVS. If you wanted to do the 90-day and not use mail order and get the lower copayment, that would need to be through CVS. But if you're just picking up an antibiotic and you're close to Costco, you can go ahead and go there or any of the other pharmacies.
We use Catamaran, Neighborhood Health Plan uses Catamaran, but again, CVS is a pharmacy in our network, but there are many, many others. If you're going to a Harvard Vanguard site, for example, and they have a pharmacy on site, you can go from your doctor's office downstairs to the pharmacy and pick up your prescription before you leave the building.
And just taking off on what Jennifer said, the only benefit of going to a CVS retail pharmacy for Unicare or Tufts or Fallon too, right, is that you'd get the 90-day copay for a maintenance medication. But any retail pharmacy is included in all of our plans networks. Thank you, everybody. So I've sent out an email on this that there was a breach. I'm sure if you've read the news that Anthem, which is the second largest health insurer in the country, had a data breach. This is the type of information that was compromised. The Unicare is a subsidiary of Anthem, and so therefore current members and former members' data could have been breached. Anthem has been sending out this mailing, and it says Anthem. It might even say Blue Cross, but it doesn't mention Unicare. So the challenge is that some members may not know that it does affect them. They do get the credit monitoring services. Unicare is going to be sending out a follow-up mailing so that members understand that it's Unicare is included. So here's the big changes that we need to go over. All of our forms are changing. There's not a form that we have that is not changing starting on the 8th of April. So any forms you have on hand, please discard them. We can't accept them after the 8th. So please, please, please discard your old forms. You have in your packet copies of all of the forms. They are all on our website. They are all interactive like they always are, so that you can, the member can enter in the information, print it out, sign it. These are easier to use, I think you'll find. The fields are bigger. There's instructions on the back. It's very important that the member get the copy of the instructions. So please be sure that the member gets that instruction page. We need the original signed form. We don't need the instruction page, but we need the original signed form to the GIC. The IDF form has been discontinued. You'll not find it on our website anymore. That information has been incorporated into Form 1 and Form 1 MUN. So because for those of you that know that our health benefits are under the tax code, Section 125, which means that they are pre-tax. That's a huge benefit. Members get their benefits on a pre-tax basis. In order to offer products that are pre-tax, there's a lot of rules and regulations that you need to abide by. And so we are tightening up our rules and regulations to make sure we're complying with those IRS requirements so that members can continue to have pre-tax health benefits. What that means is that the only way they can enroll for the first time is at annual enrollment. as a new hire or within 60 days of a documented qualifying event. We need to receive the form and documentation within 60 days of that event, or else they're subject to annual enrollment. So if they want to add a spouse, they need to do 60 days within the marriage, and do not send us the form without the documentation, because it does you no good. So big changes, where I'm going to emphasize the 60 days. It's on the forms. It is very strict. We were kind of trusting in the past, and we just can't be anymore. So don't send the forms to us without the documentation. So the documented qualifying events, and this is clearly on the form as to what the qualifying events are, so they have to check what the qualifying event is. But marriage, birth, adoption, spouse's annual enrollment, return from an approved FMLA military leave. You have in your packet a very valuable documentation chart, and that shows you all of the deadlines, shows you the type of documentation we need. And it is on our website, so we will be constantly keeping that up to date. Yes?
What will you be using for an effective date on those qualifying events?
So the effective date of the qualifying event, Paul?
Well, you've got a couple. The effective date for the qualifying event takes place in average birth on that date, 60 days from that date. At that point, the employee can either go back to the qualifying event or prospective.
We're not doing the first of the month?
In the packet, you will see what is prospective and what to go back to the qualifying event.
So that chart gives you that,
But
all
do
of
you
that
go back
information.
to the individual date in the middle of the month, or are you going to the first of the month like
If
we
somebody
typically
has
have?
to change plan and change coverage from individual to family, we have to go to the first of the month. If somebody already has a family plan in place, it can only be at birth or at marriage. I mean, the issue is that we're now up to 450,000 new people. We get 10,000 pieces of mail in that per week. And what's happening, people are sending forms, they're not signed, documentations come in, they send us a marriage certificate. No enrollment form. We have no idea who that marriage certificate belongs to. Plus, the IRS tells us, in order to this tax benefit, you have to get in and these guidelines. So we put that chart in your packet, all of the qualifying events. If there's no qualifying event listed in that chart, the police cannot do it.
So here's the front of the state version of Form 1. You can see that there's two sections clearly marked required. I've underlined decline GIC health insurance. That's for your purposes. We don't need those, but because of the ACA, you need to keep track of people that you have offered health insurance to that have declined the coverage. So that's just for your records. Here's the list of qualifying status changes. They check that. I think those of you that are from state agencies will find this new section on life insurance is much easier to fill out. It's very clear, so that if they're enrolling or increasing their coverage, it tells them what they can apply for as far as the multiple of salary or the fixed amount, and then if they have a family status change. You can see at the bottom it repeats the 60 days of the qualifying event. That's also on the back. This is the municipal version of the Form 1 MUN. You can see that the employee must fill in their date of hire. They need to also check whether they're full-time or part-time and the number of hours they work per week, required fields. You can see the spouse dependent information is there, and as you could with the IDF, if you need additional dependents, you can add a separate sheet of paper. So if somebody wants to go from individual to family or family to individual coverage, here are the list of qualifying events that when that can take place. So you can't just drop a dependent for no reason. You need to have some kind of qualifying event. This is the cancel coverage. So on the insured side, If you want to cancel coverage, if it's insured spouse's annual enrollment, birth, adoption, or marriage, that's when you can cancel coverage. And you can remove a spouse or dependent for death, or that spouse or dependent gains employment. Again, it has to be documented. That information is on the chart that you have. Then this is a new form. This is called an Employment Status Change Form 1A, or 1AMUN for municipalities. This is the municipal version. You can see you can do transfers. The transfers and terminations now take place on this form. And retirement now takes place on this form. So this helps our members walk through all of the things they need to think about at retirement. It includes the retiree dental for those municipalities that offer the retiree dental program. And then here's the 1A for the state. So the state, you can also do leave of absence. This is the form for leave of absence, for transfers and terminations, retirement. And we have added, very helpful for state agencies, those of you who know, walks them through optional life insurance, because the cost of optional life insurance skyrockets at retirement. We want them to actively tell us what they want to do with their optional life insurance at retirement. So here is a back of one of the forms. You can see that it includes mailing instructions. This gives you the combination coverage for on the 1A, as far as if you have a under and over 65, what options they could pick. With Form 1A, if they are enrolling in health insurance for the first time at retirement, they would also fill out the RS form, which I'm going to show you in a minute. That's the only time they would need another form. So we have a new retiree survivor form. This is for both municipalities and the state agencies. It's one form. So this can only be used for current retirees and survivors at annual enrollment, or if they're picking up health insurance coverage for the first time and they filled out the 1A or 1AMUN, this is the form they would need in addition. Also, municipal survivors are applying for coverage. The form cannot be used for state survivors who are wishing to pick up coverage because they need to go through the life insurance beneficiary process. This is a retiree survivor form, just so you can see it. And it gives you the under and over 65 options. And then on the right side, the person would check who was on Medicare, all that apply. Individual on Medicare, the spouse is on Medicare, or dependents are on Medicare. Very easy to fill out and very clear. So as I mentioned, we went on, the HRCMS manual is being printed now. The offline I sent today for layout, and the municipal one will follow later this week. We will mail these out to you because it is all new procedures. You can throw out your old coordinator manual. It is on, they will be on our website. All of the pages of our website are pretty much updated. But we will be mailing those out to you. Does anybody have questions on the forms before I could go off with that? Yeah.
Can you go back to the ACA amending? There is a neon box on Form 1, which I'm happy to see, because I didn't know what we were going to do. Now, for employees who already have declined health plan, should we go back to those, or is it only going forward that we go like that?
So the question is, if you have employees who've already declined health coverage, do you want to go back to them? I personally, at annual enrollment, it's a cover your own butt type of situation. So I personally would recommend that you go to those employees and have them sign a Form 1 or Form 1 MUN and say, I'm declining coverage, because that shows that at annual enrollment you offered them the coverage and they declined it. It's really the only way to track that. And we don't want those forms. You just keep it in their file. Any questions on forms?
No, I'm sorry, I just had a question about divorce.
Divorce?
If,
We don't answer divorce questions.
no, if somebody drops the spouse off of a plan,
Yeah.
but is court ordered to keep them on,
Yeah.
do you need documentation?
Yeah, we always need copies of the sections of the divorce decree. Yeah.
I have an employee who's just about ready to retire, who's never taken the insurance
Right.
because they're on the spouse's
Yeah.
insurance. The spouse is about ready to retire, and their company doesn't allow them to take the insurance once they retire. Does this person need to get on GIC before she retires in order to go with it once she retires?
No, because you're showing a qualifying the spouse is having a retirement and losing coverage.
And losing coverage.
And they can document that?
Yes.
So then within 60 days of that, they could pick up the coverage.
Okay.
That would be on your chart.
Even though they've never
Right.
carried the GIC insurance
Right.
in their 20-plus years of being a
That's right.
So, the option to decline GIC health insurance, that's taking the place of that HERD form?
Oh, the question is on HERD. HERD actually went away a few years ago because when the ACA came into effect, they did that new marketplace notice that you're required to give new hires, and it's part of your new hire procedure. But there's no documentation on that form. It's just you're giving them information. But yeah, HERD was part of state healthcare reform, and the form is discontinued. So that's why we've added it to the Form 1, just so you have some way of tracking it. Yes? Are you from a municipality?
Yes.
And you got a state form in your packet?
It's an offline.
No, you're an offline. You're considered a state agency. So anybody with a 999 agency division code, you're eligible for all state employee and retiree benefits. So that's why you get the active state employee benefit decision guide. You get your retirees get the retired state employee guide. So you are considered a state agency for GIC purposes. No. Municipalities are only for the 47 towns, cities, and school districts that are part of the municipal program for health-only benefits. Yep. Yes?
Just a quick question on this whole section on leave of absence. If someone's going out on the maternity leave, and they have enough, you want this filled out, they have enough qualifying time, say for 8 weeks, but they're gonna be out 12. Do this starting with their start date and then end date, but then the day they're off the payroll.
Right, so we still need that information.
You need all that.
Yes, and that's part of your procedure. So your coordinator manual walks you through leave of absence, all of the steps that you need to do. So please make sure you use that coordinator manual because especially something like a leave of absence that you don't do every day, it's easy to forget a step. And so just be sure to follow those step-by-step procedures. Any other questions on the forms?
Is it still going to be the Form 11 then?
Form 11, yes, that's still in place. So, let's see. So, I had sent this email out a while ago, but we are transitioning the calendar year deductible to a fiscal year deductible to make it easier for employees to switch carriers at annual enrollment. That's obviously a barrier. If I've already used my deductible, I'm less likely to want to switch carriers at annual enrollment because I have to start the clock all over again. The deductibles are increasing to $300, $600, $900 for July 1st. So if I've already exhausted my $250 deductible, yes, I'm subject to another $50 for the remainder of this calendar year. Then for January to June 30th, there'll be a half of a year deductible. So it's $150 for one person, $300 two person, $450 three or more person. The other benefits like the out-of-pocket maximum, all of that stuff is getting switched, so it's all on a fiscal year basis to make it easier for people to understand and to also to be able to switch plans. This flexible spending account is also going to be switched to a fiscal year. So we will have the open enrollment period, October 13th to December 4th for half-year benefits. So for in the fall, you'll enroll for January to June 30th for $12.70, up to $12.75 on HCSA or $2,500 on DCAP. And then next spring annual enrollment, you'd enroll for the full fiscal year. As you know, we switched carriers to ASI Flex, and ASI Flex has been more in compliant with the IRS regulations with getting documentation. It's been a little rocky, to say the least, because members have not used to getting all of these requests. They do auto-adjudicate the standard copays. I mean, and I've already given them the copays for July 1st, so they know what the new copays are going to be. We've also worked closely with them to improve their communications, because they could have been a little more user-friendly and given people a little more time for that substantiation process. And I have here today, Gordon is from ASI Flex, and he will talk a little bit about the changes.
Thank you, Cindy. Cindy suggested that unlike the other providers sitting at the back, I sit up front in case I need to leave in a hurry. If you don't use the card and you have an expense, you have to go on the GIC website, fill out a form, print it out, mail it in with the documentation. The card is very useful because it advances money where you having to spend money. But the documentation requirements haven't changed. As Cindy said, a lot of things can be automatically adjudicated, prescriptions, copays. We have a wallet card that we passed out, we mail out to everybody that you can use where you have a medical service. We've lengthened the time for substantiation. You get an initial 5-day notice. Now we're going to wait 60 days after that before the follow-up notice, and a further 60 days after that before the card's deactivated. We have about 1,900 people who had their cards turned off. Probably everybody in here has somebody in their group that, if anybody doesn't have anybody in that group that's turned off, raise your hand. Okay, good. But this is less than 10% of the people. And we're going to turn those cards back on because they may not have understood what they needed. The documentation is still going to be required from these people, but the card will be turned on meanwhile so they can use it pending that. And there'll be a letter going out. We're finalizing those communications now. We appreciate very much GIC working with us to get those communications squared away. I'll be outside afterwards for any questions. Thanks very much.
So other major benefit changes, everything's going up. It's the bottom line. Specialist tiering, all of our plans are going to tier specialists, including Fallon Direct. All those copays are going up. Inpatient hospital care. Tufts Navigator's now going to have the 3 tiers. The plans that don't tier going up to $275. The tier 1 and tier 3 copays up to $275 and $1,500. So big changes. Outpatient surgery copays increasing for all plans except for Community Choice and Plus. The out-of-pocket maximum, that's a protective benefit so that people don't exceed a certain amount. So this year, for the first time, for these plans, it'll now include drugs. And then for the Unicare plans, it's going to be $4,000 for individual and $8,000 per family for medical and mental health, and then $1,500 and $3,000 for the prescription drugs. NHP Care is now going to be called NHP Prime. Durable medical equipment and hearing aid benefits aren't going to be subject to coinsurance anymore for NHP. Tufts Navigator and Spirit and Unicare plans are on the mental health side. After 26 visits, you need prior authorization for outpatient care. For the Unicare plans, PCP visit for mental health will now be covered. And then on the dental, vision, and retiree dental, the composite fillings, which are the ones that look like teeth, are now going to be covered. Believe it or not, the silver amalgam, this is kind of gross, but it's got mercury, so You know, when somebody dies, that sticks around. So the amalgam is definitely a better option. This is, we have people motif for our guides this year. We have a new annual enrollment video, and for those of you that got the home mailing this weekend, this is promoted. It's also promoted in the guide, and it is on our website.
Welcome to the Group Insurance Commission's annual enrollment for the 2015-2016 plan year. This presentation will cover how to evaluate your benefit options and utilize tools and resources to help you make decisions. You will also learn about ways to lower your out-of-pocket healthcare costs throughout the year. Annual enrollment for benefits effective July 1st, 2015 runs from April 8th through May 6th. During this time, you have the opportunity to review your options and make your benefit selections. Take the time to consider your healthcare needs and those of your family members for the upcoming year. Evaluate your options and determine which GIC health plan is best for you. Review the benefit and rate changes that go into effect on July 1st, 2015. Be sure to do your homework even if you want to stay in the same plan. Review and weigh your options during annual enrollment. Refer to your GIC Benefit Decision Guide, which contains valuable updates and plan information. Compare the health plan features that are important to you, such as care coordination by your primary care provider, out-of-network benefits, prescription drug coverage, and mental health benefits. Consider enrolling in a limited network plan to save money on your monthly premium. Limited network plans have the same benefits as the wider network plans, but have a smaller network of doctors, hospitals, and other providers. Look for the limited network icon in your GIC Benefit Decision Guide for more information. Be sure to find out if your and your family members' doctors and hospitals are in the plan's network. You can visit the plan's website or call the health plan's customer service line to find doctors and hospitals in the network. You must specify the plan's full name that you are considering, such as Harvard Pilgrim's Primary Choice, not just Harvard Pilgrim. Also, review your Benefit Decision Guide to understand other employee benefit options being offered. If you need help in making your benefit decisions, be sure to take advantage of the resources available to you. Visit the plan's website to obtain benefit details, information about network physicians, and tools to make healthcare decisions. Call the health plan's customer service line, and plan representatives can help answer questions and find providers. And attend a GIC health fair during April, where you can talk with plan representatives and get personalized information and answers to your questions. Be sure to refer to your GIC Benefit Decision Guide or the GIC's website for contact information and health fair dates. Keep in mind that enrollment forms are due to your GIC coordinator no later than Wednesday, May 6th. If you decide to keep your current health plan, you do not need to complete any paperwork. Your coverage will continue automatically. Visit www.mass.gov/GIC/forms to access enrollment forms. Note that all GIC forms have changed for coverage effective July 1st, 2015, so be sure you use the new forms. It is important to understand that your health plan selection is binding. This means that once you choose a health plan, you cannot change plans until the next annual enrollment period unless you have a qualifying status change. Once enrolled in an employee health plan, there are many ways you can limit your out-of-pocket costs throughout the plan year. Work with your primary care provider, PCP, to navigate the healthcare system and coordinate your care. Seek care from Tier 1 and Tier 2 specialists. You pay the lowest copay for the highest performing doctors. Tier 1 specialists have excellent quality and cost efficiency scores. Tier 2 have good scores, and Tier 3 have standard scores. If you are in a health plan which tiers hospitals based on quality and/or cost efficiency and have a planned hospital admission, talk with your doctor about whether a Tier 1 hospital would make sense for you. Bring your plan's prescription drug formulary with you to doctor visits so you can discuss which tier your prescriptions fall under and see if there are lower-cost alternatives available. Drug formularies can be downloaded from your plan's website. Consider using urgent care facilities and retail minute clinics instead of the emergency room for urgent, non-emergency care. Use your health plan's online cost comparison tool to shop for healthcare services in advance. And remember, the best way to try to reduce your healthcare costs is to adopt healthy lifestyle habits. Take care of yourself by eating healthy, exercising regularly, quitting smoking if you smoke, and finding ways to manage stress. For more tips on managing your health, visit www.mass.gov/GIC/yourhealth, where you can read articles and find links to additional resources. To get started on the next step for annual enrollment, read your GIC Benefit Decision Guide and visit the GIC's website at www.mass.gov/GIC. Thank you for actively evaluating your options and taking charge of your health.
So Paul and Donna gave me a hard time in that video. There's a lot of mentions to the Benefit Decision Guide. Of course, it's near and dear to my heart. But I do want to show, we have the at-a-glance charts inside the guide this year. Should be very helpful for people. And you'll see that the copays that have changed are in bold. So big change this year. I think people will like it.
I have a question. If someone makes a change between April 8th and July 1st, but it's not regarding open enrollment, do you use the old form or the new form?
No, so the new forms are going into effect on April 8th for everything. So in your packets, you have we have that helpful provider list that gives you, for our limited network plans, which hospitals are in the plan network. If you've paid attention, compared it to last year, you'll notice that the total number of Massachusetts hospitals has gone down. That's because North Adams and Quincy have closed, and Somerville is no longer offering full hospital services. But it's a good comparison, and that chart is on our website, on the guide section of our website, so definitely refer members to it. In the video, there was a mention of the cost comparison tools. All of our health plans are required to now have a cost comparison tool on their website so that folks can shop for care in advance. What's neat about this, it shows how much of the deductible a person's used to date. It'll show the difference in copays on specialty care, and these are just a couple of the screenshots. So this is a Tufts Health Plan cost comparison tools screenshot. This is Health New England's screenshot. So you can search, zip code and find out how much your share of the payment would be. It's a neat little tool. And then this is Unicare's. So I'm going to have the health plans come back up. I do want to mention that with the POS change for Harvard, there's a change for full-time students, and Elaine will talk a little bit about that. As you know, all of our plans offer emergency care everywhere, and full-time students are the only exception of living in the service area. So full-time student can go to school in Arizona as long as we have them coded as a full-time student. So I'm going to have the plans talk a little bit about their hospital network changes, their limited network plans, out-of-area coverage, and the online cost comparison tools, and some of the promotions that they're doing on the Tier 1 specialists.
Good morning again. I'm Elaine Wilson with Harvard Pilgrim. We're offering both the Independence Plan POS as well as the Primary Choice Limited Network HMO. And the way to understand the limited network is to understand how we created the network of the full plan, the Independence POS. And I'll get to the network changes that will describe both for you. The POS has our full network of doctors and hospitals, and as you all know through the CPI initiative, those doctors are measured and scored for quality and cost effectiveness, as are the hospitals. The hospitals score to Tier 1, Tier 2, or Tier 3, and the network can change from year to year. This year, Mass Eye and Air is moving from a Tier 3 hospital to a Tier 1, so that's something to note along with the hospital changes that Cindy mentioned. There are some hospitals that unfortunately have closed this year. So that's one network change. For the limited network, that also means that Mass Eye and Air, which had been Tier 3, now that it's Tier 1, that is a new addition to the network for the limited network plan. The way we limited the network was we looked at all of the Tier 3 hospitals and had removed them. So if a hospital was a Tier 3 on the independence plan, it wasn't part of the limited network plan, nor were the doctors who were part of that hospital. So that is the hospital change and the limited network plan. So the primary choice plan is a smaller network, as you know, than the full network independence plan. And the good news is now Mass Eye and Air is Tier 1 for independence, it's Tier 1 for primary choice, and it's now new to primary choice as well. As far as out-of-area coverage is concerned, enrollees for both point of service and the HMO do need to live here in the service area. For the HMO, the limited network service area is Massachusetts proper, not including the Cape and the Islands. So mainland Massachusetts up to the Bourne Bridge is part of the primary choice limited network plan, and that's where folks need to live to be on that plan. So anyone living here in the Berkshire area or Amherst, Northampton, all of Western Mass is part of the limited network plan. If you had somebody who lived in New York, they would be outside of the service area and they wouldn't be eligible. For full-time students, the way that the plan works for full-time students for the point of service plan is very much like for the HMO. Full-time students may live anywhere that they go to school, and we recommend that when they come home from school, they get any care that they need with their primary care physician. Of course, they're covered while they're out of the area for anything urgent that they may need, and if they use our national network, they'll enjoy the benefits of having coverage at the in-network level when that care is authorized by their PCP. And if they need any ongoing care, God forbid they're skiing over the winter, they break their leg, they need ongoing care, they can have that while they're in school, but their doctor will just need to make arrangements for that. For the cost comparison tool, our tool is called Now I Know, and if a member goes online, they may compare the cost of services from provider to provider. And one of the nice features about our tool is that it automatically searches by the lowest cost provider, which for us, if the member is looking at a doctor or a hospital, will be a Tier 1 provider. So the engine will search that way first, and then unless the member puts in some other filters. So that's something to be aware of as well. And for Tier 1 and Tier 2 specialists, we promote those specialists by listing their tier in our paper directory and our online directory, and if they are also a centered care provider, we indicate that as well, and indicate the tiering of the provider as well as their centered care status. If they are a centered care provider, we'll say CC next to them. I realize you're going to have a lot of information, so I'll pass this along to Glenda. Thank you.
Hi everyone, Gani DeBarge again from Health New England. Health New England is one of the limited network options again this year with the GIC with two offerings, both HMOs, one for the actives and one for the retirees. We are an HMO plan and our network includes Hampden, Hampshire, Franklin, Berkshire, and all of Worcester counties. We just expanded all throughout Worcester last year. Network changes or hospital changes, we've just added Harrington Hospital in Southbridge as of February 1st of this year. So now members have access to Harrington Hospital as well. We do not tier the hospitals, so Health New England's inpatient hospitalization copay is $275. Members have to live in our service area to join our plan. However, if they're traveling outside the service area, they're covered for emergency care or urgent care visits. We just ask that members notify Health New England when this occurrence happens so that we flag the claim and we pay for it as if it were in network. So copay and deductible would apply as if it were in plan. For student dependents, we allow for additional services such as a follow-up visit to an emergency room occurrence, allergy injections, or outpatient rehab services. So if you have a student dependent living outside of our service area, those additional services are offered. You just again have to let us know and we flag those claims as if they were in network. As mentioned, we do have a cost of care estimator online, H&E Direct, through our member portal. So you log in with your registration, you register with your ID number. Not only will you have access to the cost of care estimator, which will allow for you to search by procedure, it allows you to see how much the providers in our network charge. So it gives you a low, likely, and high estimate for Health New England providers. Also available on H&E Direct, if you sign on, you have access to your claims information, your EOBs. So if you ever have any questions on those, if you have to print them out, you can have access on H&E Direct. Because these specialist co-pays are going up, we are doing a direct mail to members who are seeing Tier 3 specialists to highlight the savings to a Tier 1 and Tier 2. As Elaine mentioned, we will highlight them as well in our provider directory and our online provider search with a centered care logo for the PCPs. They're indicated for Tier 1, Tier 2, and Tier 3 as well as our provider directories.
Good morning, everyone. My name is Caroline LeBlanc. I'm here from Unicare. We offer the Unicare Basic Plan, the Unicare Plus Plan, and the Unicare Community Choice Plans. Our Basic Plan covers you anywhere inside or outside of the United States. There isn't a listing of doctors or hospitals that you need to stay within. You can use any doctor or hospital. The Plus Plan is similar to a PPO plan. We have a network of hospitals and doctors that you need to stay within. On that plan, you can move from a PCP to a specialist without a referral. And our Community Choice is our limited choice or limited network plan, and that plan has 55 hospitals in the state of Massachusetts. And same thing with the Community Choice plan as the Plus plan. You can move around from a primary care to a specialist without referrals. Why choose a limited network plan? On our Community Choice plan, our limited network plan, you have the same benefits as you would if you were on our basic plan, the highest premium plan that we offer that covers you anywhere, as long as you're using hospitals within that network, so those 55 hospitals within the state. One thing that's important to tell your employees is that if they are considering the Community Choice plan, they'd want to make sure that their doctor would admit them to a hospital that's participating in the plan. That's a big thing. A lot of people think, well, I can use any doctor because that's how the plan works. Any doctor is participating, but it is a limited network of hospitals. So if I know that I'm going to be having a knee surgery, I want to make sure with my orthopedic doctor that they were going to be able to admit me to a Community Choice hospital so that I could get the maximum benefit under the plan. Our Community Choice plan is the lowest premium option that we offer. And let's see here, out-of-state coverage. So on all of our plans, out-of-state coverage, you have urgent coverage or emergency coverage under the plan. You would go to the closest hospital or facility and receive your treatment. If you have a student that is outside of your service area, we'd ask that if they're going to have an elective procedure or a planned procedure, that they plan it when they come home on one of their breaks or during the summer. But they do have urgent care coverage anywhere. We offer travel access, travel network, so that if they are outside of their service area and they need services that aren't like a 911 type of service where they have to go right to the hospital, they could check and see if the doctor is participating in that network. If they are, the doctor has agreed to accept our amount or our allowed amount as payment in full. Let's see here, just want to make sure I don't forget. Our Tier 1 providers, we promote Tier 1 providers in our directory. They're bolded so that if you are looking through the directory, you'll see that the Tier 1 are bolded. You can also do a Tier 1 search on our website. So if you're looking for Tier 1 providers in your area, you can put in your area and it'll bring up all of the Tier 1 providers, which is nice. Our transparency tool, you have to log in, so it's something that you have to be a member to be able to access. But once you log in, you can search either a procedure or an inpatient stay based on the diagnosis. And what it will do is list the hospitals in the area that you've chosen. You can choose by mile radius of your zip code, or if you have a specific area that you're searching, you can put that in as well. And it'll list the Tier 1, Tier 2, Tier 3, and the cost differences so that you can see the difference in cost between the different facilities. And I think that's about it. Any questions?
Again, my name is Julia Lebrun. I'm with Fallon Health. And as you know, we have two HMO network plans. The first one being Select Care, which is our broadest network, spanning from Boston all the way to the New York border. We've expanded into southern New Hampshire. And just this year added was this southwestern Vermont Medical Center. With the elimination of North Adams, we added that facility and their affiliated physicians. That's most pertinent to this area. There were two other additions in the eastern part of the state. Whitten Hospital and Cambridge Hospital were added to the Select Care network also. We also have a limited network plan, Direct Care. Now Direct Care, again, is limited. It really is a network that goes from the Palmer area eastward. So out here in the western part of the state, Direct Care really does not have any providers available. I've provided for you today, when you checked in today and picked up, there's a little fact sheet that gives you a nice description. You can kind of see the shaded area of the state that the two networks span. And that's just a quick fact sheet for your reference. Within the Direct Care network, if there's anyone here that would have members accessing from the central state part of the state, Haywood Hospital was added to the Direct Care network. So those really are the network changes for this new year coming in. Again, with the limited networks, again, lower premiums, there are fewer providers. There are some nice pieces where the limited network, we do not tier our hospitals. Whereas the larger network, Select Care, we do tier our hospitals. So there's a few like little incentives if members have the availability to make that choice between the two. Out of area coverage, worldwide urgent and emergency care for everyone. For students, really you should be having any students receive their routine or planned inpatient care done when they are back at home during summer or breaks for their college. They can get authorized for certain services if they go back to school and they need follow-up, PT or things like that. They can get authorized there, but all that care needs to be authorized and worked through their primary care physician. We have an online cost comparison tool called Fallon Smart Shopper. You can log in and register. It's geographically based, so when you put in the zip code, it's going to give you certain providers for about 62 procedures, and it'll give you who are the most cost efficient. What's nice with our tool is your members are eligible for an incentive if they go and shop this tool and use a lower cost facility. The incentive is going to range anywhere between $25 and $500. It depends really on the service. The lower costs are going to be probably more for the diagnostic testing, and your higher incentive would be received for more of the more expensive inpatient or outpatient surgery charges. So that's a tool that's available right on the fallonhealth.org/GIC website under cost transparency. I'm going to note that incentive is kicked off based on when the provider bills. So the member may search for the procedure before going in, but it's really when the provider bill that's going to kick off the incentive. So if we don't receive that bill for, let's say, 3 months or 6 months, the member's going to be asking questions as to where my reimbursement is, where my incentive is. So just so you know that is what kicks off that incentive. And then with the Tier 1, Tier 2, our online formulary and our provider list all of the different tiers associated with the specialist. Keep in mind, Direct Care is tiering specialists this year, so it mirrors the Select Care tiering that's already in place. And again, the provider online lookup tool is probably the most efficient because a member can go in, put in where they're looking for a provider, and they'll get the providers within that geographic area. Okay?
Yes.
But with the addition of Southwestern Vermont Medical Center, are also members that live in that area, or will they be able to join the Fallon plan?
In Vermont?
In Vermont?
No, they would have to be living in Massachusetts.
Okay, thank you.
Hi again. So as far as, oh, sorry, question.
Does Fallon use some backdoor direct for eye exams under
Routine eye exams?
eye exams?
Yes.
All of our plans are
Yeah.
for routine exams.
So as far as the Navigator plan goes, the network, obviously aside from the hospitals that have closed, the network is the same. The major difference this year is that inpatient co-payments are going to 3 tiers on Navigator. But all of the hospitals that were on Navigator previously are still on the Navigator plan as long as they're still open. Same thing for Spirit. It's the smaller network of hospitals, so there are fewer hospitals on the Spirit plan. One thing to note, the Spirit plan is remaining 2 tiers for the inpatient stays. So Navigator is going to a 3-tier payment, for inpatient stays, and Spirit is remaining at 2. And that information is included in the open enrollment materials, and the list of the hospitals are on there, as well as on the microsite. So one of the advantages, obviously, of a limited network plan is that it is less expensive. If your providers are on the plan and your hospital is on the plan, it is a really good way to save money, both out of your paycheck and then trying to utilize the Tier 1 providers. The very important thing to note, though, is that it is a limited network plan, and if your doctor is not in it, then you are not going to have coverage. So keeping that in mind, it's a great option as long as your providers are in the plan. For out of area, while you're traveling, you're covered for any urgent or emergency services worldwide for both Navigator and Spirit. And students, full-time students that live out of the service area, as with the other plans, any routine care does need to be done while they're home, but they are covered for any urgent or emergency care while they're residing at school. We have an online cost comparison tool. It's called Empower Me. The names are kind of cracking me up, to be honest with you. So it is called Empower Me. You need to be a registered member. It accesses your specific benefits. It can track where you are in your deductible and your copayment. And it does list providers by least expensive for you to most expensive within your geographic area. And again, the search functions can change, but that's pretty much what the major thing is there. And also with services like MRIs, the cost range is varied depending upon where you're having the service. So you can actually like click on, it shows a little human being, and you click on the knee, and a knee MRI services will come up. Or if you need an MRI somewhere else, you click on that. So the costs vary depending upon the part of body that it goes to. In terms of promotion of Tier 1 and Tier 2, all of our hospitals and providers are listed what tier they're on. The search comes up with preferential treatment to Tier 1 providers, both in print as well as the provider search. We also have educational flyers included in our handbook, and those flyers are also accessible via the microsite.
Thank you, Jen. Again, my name is Eric Jakes. I'm with Neighborhood Health Plan. We are in Boston. We're located right on Summer Street near South Station, but we serve Greater Boston, North, South of Boston, Central Mass, and to a certain extent out here in Western Mass and Hampden County. We do have a couple of hospital network changes this year. Clinton Hospital and Marlborough Hospital will no longer be offered. We don't do a tiered hospital network. We offer about 75% of the overall network of hospitals throughout Massachusetts. So 57 hospitals are in the NHP network, including UMass Memorial, Worcester, Leominster Hospital, Hayward Hospital. So we do have a presence in Central Mass. We just don't do the two different tiers. It's $275 regardless of the hospital that you go to. We do have a limited network, and the limited network is valuable. We offer a limited network to all of our commercial business, not just the GIC. What it means is that if a group demands a certain payment, as Cindy indicated earlier when she was talking about limited network plans, we may decide not to contract with a group if we feel that that's going to have an effect on the premiums that we charge people. So if it means that there's a group over, let's say down in Middleborough, there's a large PCP group, they want a certain amount of money, we're not willing to pay that amount of money, We'd rather keep the cost down for our membership than bring that network in and add membership in that particular area. So that's how the limited network works with us. The UMass PCP group is not currently in the network for a neighborhood health plan, and I understand that that does make a decision for some people, but we do have lots of PCPs, hundreds of PCPs in Central Mass. One thing to just to note, we did have a member come to us last year, said that they were told that they could select a doctor who's not in the network, a PCP who's not in the network, but that doctor could refer him to doctors who are in the network. That's not true. You do need to have a PCP who's in the network for an HB to refer you to specialists who are in the network. As far as the hospitals are concerned, we feel that the quality of the hospitals in community hospitals like Haywood are just as strong for people as you could get if you go out to Boston. I have two personal acquaintances who had 6 months of chemotherapy at Haywood Hospital. They're both very healthy 20 years later with families. All of their care was right at Haywood Hospital. They didn't need to come out to Dana-Farber. Those are very strong hospitals, no question, but it doesn't mean that the care is not available at your community hospitals and primary care groups. For out-of-network coverage, emergencies and urgent care, if you go out to the Grand Canyon, you fall off your burro, you're definitely covered at a hospital out there. For students, one important note to make, students are covered for urgent and emergency care. Very often they need to have a follow-up visit with a specialist. We need to receive information on whether or not it's medically necessary for that follow-up. We're just not going to automatically pay for a visit to a specialist. Say someone's going to Duke University and goes to see a specialist in North Carolina. We need to have some coordination of care with those doctors in North Carolina to learn more about the condition. And we certainly do authorize them, I can tell you that, but we need to have some medical information before an authorization is provided. As far as the tiering is concerned, we most certainly on our website and in all of our materials will stress that Tier 1 and Tier 2 providers are the lower cost providers and the higher quality and higher efficiency providers. Those are the ones you want to look up first. They're indicated on all of our sites along with the centered care providers, meaning these are the ones that you want to look at if you want to save some money and also receive high quality care at the same time. And we do have an online shopping transparency tool. It's the same vendor that Tufts use, so it's going to look very similar for our members. They log in and they can put in those particular types of services that they're asking about, and a variety of different services come up. Again, knee surgery at a location in Lowell, just as quality as you could get if you go into Boston and have the services done. So the quality is out there. You don't have to go into the big city to get it.
Thank you. Any quick questions for the plans? Yes.
A question for Unicare. Could you give us a little bit more information about UMass Worcester? I've had some people that UMass Worcester has sent them letters saying that they will no longer be taking Unicare, and they're pretty upset because the plans that are not like Unicare.
Yeah, so I do want to say something before Caroline speaks. One is UMass sent it to Medicare folks, and that's absolutely not true. So Medicare folks are still, that are with OME are still being covered. And as I mentioned earlier, negotiations continue.
That's what, one thing I was going to say is Medicare members and non-Medicare members received a letter from UMass. We have mailed out to our Medicare members, letting them know that that letter was sent in error. Because Medicare is their primary carrier, they can continue to go to UMass without question. Currently, UMass has ceased negotiations, and as Eric kind of alluded to, the cost of what they were looking for was an extreme amount, and we just, with the increases this year that the state is facing, that would have just added to those costs if we were to agree to that. We are willing to try to work something out, and we are continuing to try. But UMass, anytime one of our customer service representatives mentions that, UMass is saying that there is no negotiation, that's what they want, and that's the only amount they'll accept. So we are trying to try and work something out, and it's very disappointing for us as well. But we can't just agree to whatever it is that they're asking.
I just want to point out that it's highway robbery, and I'm saying that knowing there's some UMass people here. It's the third most expensive hospital in the state, and that is doesn't necessarily warrant that kind of cost. So negotiations continue. They pulled the same stunt with one of our other plans a few months ago. These providers think that they deserve massive salaries, and they don't want to be part of the solution to healthcare costs. So again, negotiations continue, but we cannot afford to continue paying these kinds of demands. Thank you.
Excuse me?
Yeah.
You say the negotiations are still continuing. Do you have an idea of when you might know? Could you have a resolution during open enrollment for folks to know?
We would hope to have one, but it honestly...
Two people have to come to the table, and right now UMass is refusing to come to the table, so it really is not clear as to what the timing will be, and if there will be resolution.
I'm asking because I have really care.
Sure.
I go to Mass INM because I have a life condition.
Yeah.
I really have, and I really like the idea of not having to need a referral to go to school.
Yeah. Yeah.
You know, plus I live in Central Mass, and in Central Mass, UMass Memorial Wolves.
Yes, they do, but that's the same issue with, Brigham and Women and Mass General. You would think there was no other hospital out there. They're man's greatest hospital. Okay.
But there are people who have it on their plans, right?
Yes, there are.
And
Yes, there are.
which plans are they?
Yeah. So you have in your packet the list of hospitals that are in each of our networks plans. And obviously those are subject to change, but that's the list for July 1st. We have 4 minutes, and there's a couple more things I need to get to. We will be here afterwards to answer other questions. So this is the list of groups that are joining for July 1st. This year's health fairs are obviously going to be concentrated near these areas. And we have a few municipalities that are joining the retiree dental program. MetLife is going to be sending, I don't think anybody from those communities are here, but MetLife will be sending to retirees and survivors of those municipalities the new forms. So I readily admit that our website is not the easiest to navigate, and that is because we are part of the state's portal. We do not have any jurisdiction over anything at the top or in the left-hand side once you get into our site. So to get around it, what I've done is as you go into the interior of our site, there's a button to go back to the home page so you can start all over again. I do want to show coordinator information. So here, members can click on the list of all coordinators to get their coordinators. Coordinator news. So here's information on the training. Health New England is offering a breakfast. If you haven't RSVP'd and would like to go, the information is there. Ordering supplies. If you want to order provider directories, all of the information is here. Again, our step-by-step procedures are available, so we're in the process of updating all of these pages on our website. So if you click on HRCMS, all of this information, if you're an HRCMS agency, has been revamped to show the new forms and procedures that are effective, and the download of the manual will be here. And all of that substantiation, documentation, that's there. If you're on our homepage, the most frequently used section of our website is Answers to FAQs. That's here, and it's also here. If you go to Answers to FAQs, this is the most used section of our website. So folks that are getting laid off, have a leave of absence, all of those questions and answers are right on our website. Benefit decision guides, all of the content of our guides is on our website. As you know, we have 3 versions: active state employees, retirees and survivors, municipal guides. If you click here, it'll take you through all of the sections of the guide, and it's all ADA accessible. And benefit enrollment, all of the forms have been updated. So it's, again, by who you are, you identify who you are. And if you are existing municipal folks, here's the new MUN, for example. Here's the 1A form. So all of that is on our website, a great resource for you. The active guide shipments are beginning on the 1st through the 3rd. Retirees and survivors get them by mail. They're on our website now. Most of you have probably received your annual enrollment home mailing. And I will be sending out to you an email to go out to your employees. If you're on the state's listserv, it'll go automatically. If not, we ask that you forward it to your employees. We are going to have sign language interpreter services at 2 of our fairs. That information's on our website. If folks need translation services, they can call into the GIC, and we have staff that speak a variety of languages. I also want to mention to those of you who don't know that there is a free service for you through our contract with Beacon. Beacon has taken over Value Options. You may have heard of Value Options. So the name of the plan is changing from Beacon Health Strategies to Beacon Health Options as of July 1st. But Sue Cooper continues to provide these services. These are free services for your supervisors and managers, and also critical incident debriefings if something tragic happens at your agency. Definitely something to keep in mind, and her contact information is there. Does anybody have any other questions? We will be here afterwards. Yes?
Were you telling people to be aware that their premiums might be 25%?
So that actually is in the guide. The question is that state employees, should state employees be aware that their premium may go up to 25%? House 1 included language to change all state employees to 25%, so that warning is on the rate page in the guide. That doesn't mean, the budget, who knows what's going to happen in the budget, you know? We could all use crystal balls, I think. Yes? So Kelly's question is, does it affect retirees? That's separate legislation. So as you know, there's a couple of legislative proposals out there. One of them would increase the retirees' premiums for retirees who retire on or after a certain date. Again, we don't know what's going to happen, but part of House 1 actually would move all state employees to 25%. Yes? The question is on new hires, I'd go ahead and use the new forms. Yep. Thank you.